The management of vitreous seeds in retinoblastoma prepared by myself and Christina Statopoulos at Gulgona Eye Hospital in Lausanne. So for those who are interested, all what I will be talking about is treated in more depth in this paper recently published in Progressive Eye Research. So here's the synopsis of my talk. We'll first see what we are going to target with intravitreal injections. We'll also review the investigation tools I like to use in this context. We'll see the seeding regression patterns, the safety enhanced technique, then the drug regimen and number of injections. We will also touch how to avoid melphalan-induced choroidal retinal toxicity, and I will end with my final recommendation. This slides to show you the three seeding patterns of retinoblastoma: class 1 or dust, class 2 or spheres, and class 3 or cloud. Now, importantly, I would like to insist on the fact that intravitreal injection can target not only vitreous seeding, but also retroaloid seeding, as well as epiretinal and epipapillary seeding. Just here to remind the difference between vitreous and retroaloid seeding. Of note, the fact that retroaloid seeding is contained by the vitreous base, whereas vitreous seeding can, but not necessarily, project in front of the ora serrata, as shown also on this UBM picture, but is contained by the anterior, as you see here on the UBM of this montage. Now, there are several investigation tools I like to use for seeding. The first is optic coherence tomography, and the second is ultrasonic microscopy. And I just will review the main reason I use them. So in the operating theater, I use the spectralis flex, and for the UBM, I use the Aviso, preferably with a 50 megahertz probe. Optic coherence tomography is extremely useful to document early epipapillary or epiretinal seeding that is still invisible ophthalmoscopically. As shown here on this picture, you have, of course, seeding here in the vitreous, but you have seeds that are sitting on the optic nerve and even in the optic cup before and after intravitreal injections only. Now, optic coherence tomography is also instrumental in monitoring the seeding response to intravitreal chemotherapy. These are sequential pictures of the response at diagnosis of the seeding. You have here the seeding sitting on the retina, epiretinal seeding, and after first and second injection in the vitreous. What you observe first is a fragmentation of the spheres, followed by an increase in reflectivity. As soon as I see this increase in reflectivity, I know I can inject. I have to inject one more time, and this will be enough to get rid of this disease. Of course, and you don't have to necessarily wait to the complete response of seeding, characterized by these four types, type 0, 1, 2, 3. You don't need to reach this point necessarily. As soon as you have the fragmentation and the hyperreflectivity on the OCT, you can stop injecting. Now, ultrasonic biomicroscopy is also instrumental because you want to make sure that your vitreous disease is not going to actually migrate through the hyaloid into the Petit's canal of the posterior chamber and be in the aqueous, because you're not going to treat efficiently a disease that is in the aqueous with vitreous injections. You will need for this also intracameral chemotherapy to get rid of the seeding. Now, regarding the safety enhanced technique, this is well adopted around the world with the paracentesis and the cryo of the entry site. Now, in terms of regimen, you have basically two drugs. You have melphalan, which is in itself proposed in two formulations, with propylene glycol, Alkeran, or without propylene glycol, Evomela, and the usual dose is 20 to 30 microgram. And you have also topotecan, more recently introduced, also with the same dose. And what I recommend for the number of injection is for dust, 2 injections, for class 2 or spheres, 3 injections, and for clouds, 4 injections. Now, these are the results you can get with a combination of intra-arterial and intravitreal injections. In this case, where you have also a cloud, not only in the vitreous, but also a retroaloidal cloud. Here, vitreous cloud, or here, subreal seeding and vitreous seeding treated by intra-arterial and intravitreal. Now, what about efficacy? This is quite amazing to see that melphalan is nearly 100% efficient. We have only 2 or 3 cases out of 250 that resisted to melphalan and required topotecan on top to control the disease. Topotecan, we don't know yet if it's as efficient as melphalan, but based on the publication of Rao in India, it looks like they had complete response in all the cases treated, but it was a limited series of cases. Now, in terms of toxicity, we have to acknowledge that melphalan is associated with a choroidal toxicity in nearly 40% of the cases, and whereas topotecan apparently has a very low toxicity, if any, and this has been also presented by Rao in his paper in 2018, and also by the New York group in 2020. Now, there is now a trial, a prospective trial with topotecan versus melphalan that is given for intravitreal injections to decide if it's as toxic and as efficient. Now, just to remind that toxicity has been graded 1 to 5. You have the reference here, and I think it's very important to use all the tricks to avoid high-grade melphalan-induced retinopathy. And here are two important tricks. One is to avoid paravitreal injections, and secondly, to limitate the final vitreous concentration to less than 10 microgram per ml. This is one thing to avoid, is to inject in the Cloquet's canal, as seen in this case, where you had a dramatic toxicity on the macula and the retina at the posterior pole. Here is also a major complication, grade 5, by injection in the retroaloidal space, where you end up with this devastating effect. Now, a last thing to consider is the final concentration, which is dependent on age, the vitreous volume, and which is dependent also on the remnant tumor volume in these eyes. This is the formula. And so we end up with this ABAC showing the ideal dose you want to reach in the vitreous between 6, more than 6, but lower than 10 microgram. And we have also the advice regarding the dose to use, depending on the tumor volume and the age. Now, my final recommendations to reduce the ocular toxicity is to perform a 10 megahertz ultrasonography to document the yelloid status and inject anteriorly to the posterior yelloid. To perform a clear cornea paracentesis with a 34 gauge needle to allow a lower melphalan concentration through a higher injection volume. To use a 33 gauge long needle, 3 to 3.5 millimeter, from limbus to inject and position the needle under the operating microscope, just behind the lens, in the center, to avoid hypotony and other complications at the level of the intersegment, like uveitis and things like that. Avoid paravitreal, of course, injections by observing the cloud formation under the microscope. To use for axial lengths below 19 millimeter, 20 microgram and not 30 microgram. That's just an example. Prefer meridian of a pre-existing chorioretinal scar, and to re-inject at the same meridian to prevent retinopathy extension. So with that, I thank you for your attention.